with that, I'm going to come to my talk, which is basically on targeted biopsy in uveitis. We do a lot of biopsy in patients with uveitis. So I'm going to talk on biopsy in uveitis. It could be ocular, extraocular. It could be the retinal, chorioretinal. It could be conjunctival, aqueous biopsy, depending on what you're looking at. Just quickly going to go through certain extraocular ones and then maybe get down to vitreous biopsy, depending on how much time we have. So typically, this is the commonest thing that you would do. I'm pretty sure all of you might be already getting it done without actually realizing it's actually a biopsy, just that we aren't doing it. So in patients with granulomatous uveitis, typically tan uveitis or intermediate uveitis, in which you want evidence of the underlying disease, you always request your physicians, your pulmonology colleagues, and maybe your surgeons to try and get a lymph node somewhere, either in the chest or if it's more accessible in the cervical area or axillary lymph node, put a needle in, and then if they're able to give you some kind of information on what the etiology is, whether it's granulomatous or not, or best still just in TB cases, just demonstrate an AFB. That's the commonest biopsy we do. It could be from the lacrimal gland and other things as well. We had some work on that, but again, not going into that today. This is a good case. So I'm going to be showing you this case and quickly go through. This was actually a young Indian male. He had gradual painless vision loss in both the eyes, 680 in both the eyes. His family, as in his father, had lost his life due to unknown illness in pretty much the same age. He was systemically not doing well. In fact, he was admitted with the neurologist, and that's when he actually came to us. So he had episodes of severe dizziness, fatigue, had erectile dysfunction, and had all kinds of supinator and pronator reflexes which were off. So on presentation to us, actually that's what he had. The cornea had, and this was bilateral in both the eyes, had those pinpoint white sago grain type lesions. And on the, if you would look at that slit picture, and this is focused just on the anterior vitreous face behind the lens, you can see those wool-like kind of deposits / opacities, whatever you would like to call them. That's the fundus. Those are the montages of the fundus. They don't look particularly striking, but you can see that there is a microangiopathy because there are cotton wool spots. There are a few microaneurysms as well. This patient actually had, after a systemic examination and an ocular examination, his findings were very suggestive of amyloidosis, and he actually went ahead and after our consult, because they had a big differential of degenerative diseases, a family history also, that he actually underwent ulnar nerve and abdominal fat pad biopsy, and both the Congo red and the HME showed that he had familial amyloidotic polyneuropathy. So again, something where targeted biopsy extraocular is being done, which is going to help which is helping in diagnosis based on your clinical findings and your examination. Coming to extraocular biopsy, this is systemic. One of the examples of extraocular biopsy, this female, was a known case of stage 0 CLL. So it was actually news to me that chronic lymphoid leukemia apparently is very, very common. It's almost as common for the hematologists as conjunctivitis is to us. So they see a lot of patients with CLL, and if they are stage 0, they don't treat. Every 3 to 4 to 6 months, they will just do a few tests and monitor them. So it's a very common disease. However, this lady had certain other symptoms which had happened over the past couple of, about 2.5 months, and she had received topical steroids off and on. And whenever she used to use them, this red patch, which she said was superiorly, used to go away, and then it would come back the moment she'd actually stop using it, the steroids. On the ultrasound, you could see that the eye was quiet. There was no visual complaint. She was 6'6", but you could see that there's that episcleral extension of that lesion all the way posteriorly. There's the typical epibulbar kind of involvement which is seen in these kind of, and given that the patient already had CLL, stage 0 mind you, and if we were even contemplating or suggesting that she had subconjunctival or conjunctival lymphoma, it would have graded her all the way up to stage 4. So it's a big call to make, and you can't make that clinically. This patient actually underwent a full thickness conjunctival biopsy, which is easy to do, as you can see there, that red fleshy mass, and I actually just cut this out. This video is not something that we need to see. I think it's fairly easy to do. The us to get a good enough sample, and I actually in this case took a full thickness conjunctiva and tenon sample and then went ahead and sutured it. What this patient actually had was, the histopathology actually showed that the excised conjunctiva and tenon had CD56 and CD3 positive lymphocytes, which were matching with her when she was diagnosed with CLL stage 0. The immunohistochemistry, the flow cytometry was same. So it just and it just showed that it was the same presence of cells there, and the same line of cells which was more in the blood was now infecting the conjunctiva. So she was bumped up to stage 3, started on chemotherapy, and once the blood parameters were done, they were also very high. So again, one of the conditions where an extraocular biopsy has helped make a diagnosis and hopefully made a difference in the patient's life. Coming to this, we're going to come to active biopsy is pretty much a vitreous stat, and you can do that for various indications, viral etiologies, your retinitis, suspected toxoplasma, atypical cases, maybe even for tuberculosis if you would like to. So that is easy. I'm just going to skip this case and come down to some, some of the vitreous biopsy cases if we can discuss them. Yeah, so coming to vitreous and subretinal biopsy, so generally you would want to do them when there's a diagnostic dilemma. Despite your clinical exam, you've run a lot of tests, you've done a lot of imaging, but you still don't have an answer. Or you might think you have an answer and you treat accordingly, but the response is not accurate. Or, it's just something that you saw and you've never seen or read anything like that ever before, so it's atypical. Or a patient already has a systemic diagnosis or an ocular diagnosis elsewhere, but the presentation is the complete opposite. Even the media is just, so hazy. There is so much of inflammation in the vitreous cavity that a good, confident clinical exam is just not possible. So all of these would be pretty decent indications to go ahead with vitreous surgery, with vitreous biopsy as a primary kind of treatment to try and get to where you're going. This must be taken with a pinch of salt. I mean, it's fairly easy to do with micro-incision vitreous surgery, and given the right indication, picking the right patients, the outcomes are pretty good. But I think this must be discussed with the patient that even with all the relevant tests, about 50% of them, even after the vitrectomy, will not have a diagnosis. Only 50% will. That number goes up significantly if your preoperative possibility is either infection or a neoplastic etiology. So if you're suspecting, let's say, a masquerade or let's say acute retinal necrosis, which is atypical, which you aren't able to see, and you were to do diagnostic vitreous surgery for them, the positivity, the outcome rates would be much higher. And of course, you have your regular complications that you would have with any vitrectomy, and except that the chances of glaucoma/hypotony and cataract progression are higher in these eyes compared to your regular post-vitreous surgery patients. This is some of our work on this, and I'm going to gloss over this. This is one of the patients in which vitreous surgery was indicated. This is similar to what Shimmer showed. This patient had a chronic liver illness, was given 5 days of ceftazidime. However, that submacular abscess burst and had that. And since it was bang on the macula, and he was being treated with the antibiotic which was suggested that he be treated with, and he was still not responding, we actually went ahead with vitreous surgery. This was first followed by started with taking a good vitreous sample. This was a diluted routine sample as we would take. This was not an undiluted sample. And then once we went closer to the lesion, as you'll soon see, we also proceeded to very carefully take a sample from the source, because that's where your chances of picking up the organism are the most, right there. And this maneuver has twofold benefits. One, and most importantly, it will give you very good tissue to try and get your diagnosis from. And second, because it's out getting into the vitreous, covering the fovea, it also has a therapeutic benefit. So at the end, intravitreal antibiotics were injected, what this patient actually had Klebsiella pneumoniae, which was resistant to ceftazidime, which is what we were giving him all along, and eventually that's what he scarred down with, and did okay. So this is your regular infective, kind of preoperative suspicion in which you did a diagnostic vitrectomy. Now, the other thing that I mentioned was if your suspicion is of a neoplastic etiology, which was this, so for this patient, this elderly man man actually presented with bilateral, the gradual painless diminution of vision since 3 months. He was diabetic, status post, coronary stenting also. And his vision was 1/6. He had 1+ vitreous cells. And you can see how those multiple occluded vessels, some hemorrhages along the upper temporal arcade, and those dull yellow deposits along the superior arcade and inferiorly as well. The left eye had more dramatic, those yellow subretinal, lesions, deposits, whatever you might want to call them. And the fluorescein angiography actually showed you all those lesions and the part of the retina which was involved, and showed the typical leopard skin appearance that is suggestive of the etiology that I'm pretty sure all of us are thinking that's just a blown-up image of the same, and the left eye was actually no different, and you can see that the leopard skin appearance is a lot more widespread here than is clinically evident. So the suspicion was a lymphoma, but you have to prove it. You can't just put a patient on local and systemic chemotherapy based on suspicion. Your hematologist will not believe you, so this is how we did a surgery for this patient. Actually, vitrectomy was begun similarly as you would normally do, except that, the infusion was switched off, and the initial infusion was with air, because in this case we wanted to take an undiluted vitreous sample first. Then we shifted to, we shifted back to DSS, got a big vitreous sample, detached the hyaloid, and you can see these non-confluent yellow subretinal, those marked chunk of cells. And we proceeded to get a biopsy right from the source. So we made an opening with the soft tip there to access the subretinal space, and then passively through that soft tip, sucked out some of those cells, did fluid air exchange, some laser, gave this patient SF6 tamponade, and that was that. And this is the outcome of the biopsy. Subretinal aspirate actually showed atypical cells. It was CD20 positive. This is how the patient was subsequently treated with systemic chemotherapy, and he did pretty well. So, just showing one patient in which, if neoplasm is something that you're considering, then that is what you must look at strongly. Considering a diagnostic vitrectomy, maybe with a subretinal biopsy as well. I'm going to skip the other videos of this. I'm going to show you one video. This video is courtesy Professor Ramandeep Singh. Sir was kind enough to give this to me, and this is chorioretinal biopsy, which is full thickness, which is a lot more difficult, a lot more challenging, carries more issues with it, and so this patient actually presented with, had those kind of lesions, and had actually received the Ozidix implant elsewhere for this. And this, these multifocal retinitis lesions with pigmented scarring actually had spread all over. A week later, after he presented with this, he actually came with sudden loss of vision and had very dense hemorrhage. And as you can see now, the retina is not visible at all because it's all covered by blood. And, it's also intragel hemorrhage. So we're not cutting the retina as yet. That is actually the thickened hyaloid sheet which had blood over and below it. So you'll soon see some of the retina below it with those yellow lesions. After cutting that thick fibrous pacified posterior hyaloid layer and very carefully removing those localized pockets of blood, we were able to then visualize, as you will now soon see, those yellow full thickness necrotizing retinitis lesions all around, along with areas of occlusive vasculitis which were lasered. An appropriate site where we thought we could access this fairly well was chosen, as you soon see there, and it was 360-degree demarcated all around with near confluent laser for both purposes, both hemostasis and for marking. And the decision was taken to go there because A, it was accessible, and B, we wanted to get part of the diseased and the healthy retina, because that helps our histopathology colleagues look at the change in morphology. And after doing that, a second port was made, and using intraocular scissors, that square-shaped graft was actually cut, taken out, similar to how you would do in a case of an intraocular foreign body, and this precious tissue sample, which actually came out in two parts, at the retina, and the other one was, I I think RPE and full thickness choroid. So this was actually removed and brought out as so, and that was the other part of it. And this was actually sent for histopathology in formalin, and this patient subsequently did fairly well from the anatomic viewpoint. Just to show one patient who had underwent a chorioretinal biopsy, which is a much more aggressive and a tough procedure to do. We have other, you can have biopsies like enucleations and removal of other things, but I think all of us are fairly aware of that. So I'm going to end this talk here, and if there are any questions, I'll be happy to take. And following which, I think we're just in time. We have 5 minutes to go, if I'm not mistaken, and then our reception course time is over. Thank you.
It was a nice talk, Mohit. I think you had those cases of using microscope integrated OCT.
I skipped them.
You need to talk about that. Can you share your experience about that? Is there any role of MIOCT? Is it a must we have to use that, or it can be used in few cases?
Absolutely. So a quick answer would be, sir, it's not a must for those, but if you don't have an MIOCT, it's not like you can't do those cases. But they definitely help show what you're doing, especially in regions which are low and flat, in which you can't see those cells moving into your aspiration line. And they actually show you in real time that there is movement of cells through the capillary action up the soft tip, which you can very, very, very clearly visualize. It's not essential, it's just a good tool, sir. I would say that.
Another thing, so, when you are taking the vitreous sample in these eyes, would you like to alter your vitrectomy settings in any way while taking that sample?
Yeah, absolutely. A couple of points which were missed by me, and thank you so much for pointing that out. I think stopping of preoperative steroids, if the patient or any other immunosuppressive therapy the patient is on, ideally for a couple of weeks, or minimum for 10 days, and also while taking the vitreous sample, getting the cut rate all the way down to 600, 800 cuts per minute, maybe a little lower if you're comfortable. I generally tend to feel like, maybe cause a break somewhere in the periphery, but be very, very careful that you don't want to be at 10,000 and 7,500 cut rates per minute, because your cutter is going like that, and you need viable cells for the morphology to be seen. So the cut rate has to be slow, and that's what you'd like to do. Absolutely, that is one very, very important critical step in the initial part of biopsy.
So I think one point that often gets missed is that this is a very precious sample that we get from the eye. Absolutely. And if we don't have the facility to process them and transport them in the given time frame, which is a very short time frame, it's better not to.
This should not be done. Absolutely, I completely agree. If you do not have the facilities and the collaboration with your cytopathologist slash histopath colleagues, it's best to refer to a center who has that kind of multidisciplinary team set up, because you can't do everything for this patient. You can do nothing for this patient other than surgery, informing the patient, informing your colleague, and sending the sample over. They have to be ready to receive it and report it on as urgent a basis as possible, because these cells will degrade very, very fast. Absolutely. Thank you.